this session is being recorded. A PDF of today's PowerPoint will be located in the Whova platform. And throughout this, you can pop your questions in the chat. We will have time for Q&A about the last 15 minutes at the end. So please feel free to put your questions as you think of them in the chat. And with that, we'll go ahead and get started.
Thanks so much, Becca. Good afternoon, everyone, and thank you for joining today. My name is Aisha Saida, Senior Program Manager at the American Hospital Association. Maternal health is a big priority for the AHA and its member hospitals. Through the AHA's Better Health for Mothers and Babies effort, we are bringing awareness to effective evidence-based practices hospitals are using to improve outcomes for moms and babies. In today's breakout session, you will hear how hospitals are using different types of initiatives, whether it's in the labor and delivery unit or in postpartum phase, to support women and children, women and families experiencing an infant loss, and also providing resources to those with babies in the NICU. According to the CDC, infant mortality affected 20,000 babies in 2020, and every year 10 to 15% of babies are admitted to the NICU. Many factors impact infant mortality, such as stillbirths, birth weight and defects, heart problems, and more. Hear how healthcare organizations such as Dell Children's Medical Center, Hand to Hold, and Northwest Community Healthcare are working to provide support and resources for families affected by infant loss and NICU admission. Here are some of our learning objectives. We want you to take back some things that can be helpful in your work. You will be able to understand some different approaches healthcare organizations are taking to identify the needs of those families that are experiencing such loss or have a baby in the NICU. Hear how hospitals can partner with other organizations to build a repository of resources that they can use to support families, and learn how hospitals are adapting workflows to better support NICU and infant loss, those affected by NICU and infant loss. And then also understand some of the challenges and opportunities in this work. With that, I want to introduce our speakers. Today we have Dr. John Lloyd, who's the chief of the Division of Neonatology at Dell Children's Hospital, and an associate professor in the Department of Pediatrics at Dell Medical School of the University of Texas in Austin. You will also hear from Rachel Astorga McCain, Director of Programs at Hand to Hold, and Jill Kottmeyer, Director of Wellbeing and Bereavement Services at Northwest Community Healthcare. With that, I want to turn it over to Dr. Lloyd.
Good afternoon, everybody. I really thank you for taking some time to chat. This is a topic that's near and dear to my heart. I'll tell a little bit of my own story in a minute. But I'm going to start, which will hopefully encourage everyone some with how far we've come. But I'm going to start a little bit with trying to lay some of the scope of the challenge. And so if you can go to the next slide. As the slide says, I'm a neonatologist. I've been at this for 20 years. I've been here in Austin for that duration. We have resident fellows and a really vibrant community, cover 8 different hospitals. We have a freestanding children's hospital with a delivery unit, all the way down to a level 1 facility. So my team covers that full spectrum. So I get to see how this challenge plays out in a number of different settings, which would make sort of our world applicable really no matter where you are. What I want to do is just start by laying some scope of problem. And as you can see here, there are lots and lots of premature babies that are born in this country. We've been right about 10% for some time now. The number's slowly going down. And if you see that graph there, you can see the burden of prematurity is not evenly distributed across racial and ethnic groups. Black women in this country are, as you can see, they're 50% more likely to have a premature baby. Now, if you look at the most premature babies, they are 3 times as likely to have an extremely low birth weight baby, which is 1,000-gram baby. If you try and understand what that means, really for the last 70 years, our infant mortality, which is death in the first year of life, has been driven by our neonatal mortality, which is death in the first 28 days of life. That is largely driven in Western industrialized countries by birth weight distribution curves. So it means how many little bitty babies that you have. Because these rates here you can see of about 10 on average. If you look at our smallest babies, the 22, 23-week babies, those babies are going to die at about 600 per thousand. So you can see how the distribution of small babies can be very influential and really is largely what drives our death within the first year of life in our children. You can go on to the next slide, please. What I wanted to show here as well is that the problem is not only significant for our babies, but it is significant for our mothers as well. And you can see that pregnancy-related deaths in this country also are not distributed evenly across racial and ethnic groups. That truth, that sad truth, has held out over numerous epochs, as shown in the last graph there. Pregnancy-related mortality in this country is 5 times higher for Black women than it is for white women of similar education. And even if you take the most highly educated and well-resourced Black women in this country and compare them to the lowest resourced group of white women in this country, that unfortunate ratio or that unfortunate disparity continues, although is the best. Next, please. Just wanted to show a dad here in one of our units holding his babies. This baby over on the left side is about a 2-pound baby. We have babies that we take care of that are down to less than a pound, 12, 13, 14 ounces at times. When they're born at the smallest gestations, when everything goes really, really, really well, they're going to be in the hospital for months and months. You can go to the next slide. You can imagine what a life-changing and life-altering situation that is. What I wanted to, this is a mother and a baby that we took care of at Dell Children's Hospital. She had a little girl that was born at 2 pounds that had a very severe and, if not treated, lethal heart defect. So you can see the picture there on the left of the little bitty baby. This was at about 3 weeks of life when we took the breathing tube out the first time. But you can see that there was an incision there on the chest, so they had to do open heart surgery on this 10-day-old baby to basically switch the large vessels that come out of the heart. The heart itself was formed normally, but the big blood vessels were twisted or backwards. And so they had to go in at 10 days and switch those. This baby went home and did very, very well, but was in the hospital for 4.5 months. What you see in the graph there to the left is that there is a dose-dependent impact of NICU on negative impact of how long you're in the NICU with respect to mental health challenges. And you can see that the percentage, if you're there less than 2 weeks, is about 19%. And it's about double that, from about 20 to about 40 if you're there longer than 2 weeks. We in our site, we see tremendous differences between our large delivery hospital, which we'll go through some of this a little bit later, where we have a lot of prematurity. The conditions tend to be less severe, into our children's hospital, where we have It's a little smaller unit, but does tend to have much sicker patients. And the truth that duration matters, but also the number of times you have to walk into families' rooms and talk to them about potential death or disability or challenges of their babies is associated with just terrible psychological, emotional, spiritual, and economic challenges on every single one of our families. You can go to the next one. What I did here a bit is to show that we're doing a fair but far from perfect job of screening our families. You can see the second to the left set of bar graphs show the number of women that are screened, and fortunately, the racial disparities there in the screening is less than we see with the birth weight challenges and the maternal mortality challenges. And then you can see the number that actually screen positive for depression, and then those screened for postpartum depression, and then those who had symptoms by race. So it is a very significant problem. You can go to the next slide, please. Here, I just wanted to show that we're increasingly taking care of our families in Texas on Medicaid, that we have a significant burden of uninsured women of childbearing age and of children in our state. And so we've got a lot of work to do to appropriately provide the needed medical support for the women and the children in our state. And going to the next slide. So what I'll do is just finish up a little bit with the burden of this. Then I'll kind of go back a little bit to talk about, though we've got a lot of these challenges, we have come a long way. And then I will close up with the story of what we've done at Dell, which will lead nicely into the hand to hold conversation. So the cost of this, kind of when put in economic in an economic language, is over $2 billion in the state of Texas. And the way that's calculated is by lost wages and all metrics added to show a significant burden economically. But the mortality that we see in our state and across the country is not limited to immediately postpartum, but a significant portion of the mortality does occur beyond the first week, within the first year following delivery. So the challenges associated with pregnancy are far-reaching. They're not they extend beyond the delivery room, and are something that we need to be very cognizant of and provide resources and support for these families. You can go to the next slide. So here I'll pause a bit, and you can see that prematurity impacts our society in a very significant way, that it impacts the babies. There is a psychological burden, a dose-dependent burden of the NICU and these sorts of psychological challenges associated with having a baby in intensive care unit that do impact families. As I said, it does so in a dose experience based way. And it's an expensive problem for families, for individuals, and for us as a community. But if I go back to my story, and this gets a bit to how I actually met Kelly, who's the founder of Hand to Hold. When I moved to Austin, I don't remember exactly who told her the story, but someone told her there was a neonatologist here that was born prematurely. And so she started knocking on doors and eventually got to me. And, someone said, you were born prematurely. And I said, I was. And so we started talking. So I was one of her preemie power champion. I don't even remember exactly what she called it. But my story, uh, personally, really touches on a lot of these areas here because my mom ended up having a terrible eclampsia. It was a time before the late 60s when it was not nearly as well understood and monitored as it is today, but ended up having a stroke, hypertensive stroke in the OB's office, did an emergency delivery on her there. She ended up passing away 3 days later. I was 29 weeks and 3 pounds. And so to put all this in context, back in the 60s, late 60s, a baby like me, even if you take out can you get the baby out fast enough in a C-section and that part of it, but just being 3 pounds and 29 or 30 weeks, that baby then had a survival rate of about 50-50. And you kind of either had lung disease and you pretty much died, or you didn't have lung disease and you could live. Today, that same baby has about a 98% chance of survival. So we have come extraordinarily far in the medical management of the babies that we care for. If you go back to the late 60s, they would have said the limits of viability would be somewhere in the 25, 6, 7 week range. Today, in the most sophisticated centers, babies down to 22 weeks have reported single center survival rates into the 60% range. So we have done a tremendous amount of work helping premature babies survive, helping families who are challenged with prematurity take their babies home. We've done a tremendous job in decreasing, although it is still a significant problem, maternal morbidities like the one that my mother suffered. I mean, every woman as they go in, they're screened and monitored in a far more sophisticated way than they were 50 years ago. The part of the story that I don't know that Kelly's heard is that you can imagine how much focus was placed on the mental health of my father back in the late 60s. You look at generational issues and kind of gender issues and so it was at a time when mental health was not something you talked about. Go into a family like ours, certainly the men wouldn't talk about it. You didn't cry, you just shoved everything down. You kind of continued to get up and go to work. So he loses a wife and then has a baby in what rudimentary NICU they had 50 plus years ago. And there was not a single person professionally who was involved with trying to see how he was doing and looking at his mental outcomes and health. And so we have come so far that we have a conference where we're talking about the impact of these conditions on the mental health, mostly of mothers, because they certainly bear the biggest burden there, but it does impact families. And so we have the fact that we're here having this conversation as compared to where we were 50 years ago. We've come so far, but have so much more to do. And so how did we, like looking at all this, how did we start dealing with this here in Austin? We, in our delivery hospital, which takes care of about 6,000 babies a year, delivers about 6,000 babies a year. We brought Hand to Hold in 2017. You can see one of our mothers here holding her premature baby, talking about the impact of having this service in there to provide peer-to-peer support and encouragement for the families there. And we had such an overwhelming positive response to this that you can go to the next slide. that we would have families that would move from our delivery hospital into our big children's hospital if they needed surgery. And consistently we would hear, why don't we have this service at Dell Children's Hospital? And so we, over the last number of years, have brought Hand to Hold in to partner with our families. We have an integrated mental health team within the NICU. It's a psychiatrist, it is a psychologist, we have a social worker, we have a case manager. And this team will follow families from prenatal in our fetal center to delivery now in our new delivery unit in the Children's Hospital, and then continue to follow them into the NICU. As you would imagine, if you were a family and told that your baby was going to be born with a significant issue needing surgery, this concern and stress and angst starts, sometimes even months before the babies are born. We have nurse navigators that are there to participate and shepherd the family through these various places where they receive care and interact with our health system, as well as a strong chaplain service. We have a center for resiliency, and then resources where the families can stay on site in our Ronald McDonald House, but then also in Texas are fortunate to have a pilot program called PeriPan, which is a telemedicine supported psychiatric support for primary care physicians and those in the hospital to help put in contact psychiatric healthcare providers with mental health care providers with patients. You go to the next slide, please. So in Dell Children's in 2021, you can see here some pictures of our ribbon cutting and a testimonial from one of our families, but it's been a tremendously well received and positive partnership to help kind of address these challenges as we've discussed with our families. You can go to the next slide, please. As we close up here, we've come a long way. We have a lot to do, but I did want to put a plug in here for the extension of our postpartum coverage for our mothers. The importance of things like paid maternity leave, statewide funding for provider to provider access through things like PeriPan. You could see that it only covered part of our state. It really, I think, needs to cover our whole state, our whole country, where we can get telemedicine resources, which have been proven very effective in helping address mental health issues for families. And so I'll leave that with you, and we'll have time for questions. But thank you for giving me a few minutes to tell my story.
Thank you, Dr. Lloyd. Now I'll turn it over to Rachel.
Thank you. Hi, everyone. I'm here to share about Hand to Hold and our partnership with hospitals. And we exist to provide personalized support before, during, and after a NICU stay so that all families will thrive. And that does include families who experience a loss as well. Next slide, please. So we officially became incorporated in 2011 as a 501c3 nonprofit, and we're based out of Austin, Texas, where we serve families locally in person and across 3 Texas cities. But we do serve families all across the country with virtual programming, and very proud to say that last year we were able to serve over 32,000 families. Next slide. So a little bit more about us. Here pictured is Kelly, who is our founder and CEO. And she often shares her story, which she says she was very fortunate to have all the resources that one could ask for when experiencing such a traumatic experience. She had her husband, she had her parents, her family, friends, church. But despite all these people surrounding her, she still felt so alone because no one understood what she was experiencing. And when she finally had the courage to speak up and say that she wasn't feeling well, that things didn't feel right, um, people told her that was to be expected. Of course you're sad. Of course you're worried. Of course you're anxious. Your baby was born so early, so premature. And it turned out that Kelly was suffering from a postpartum mood and anxiety disorder, and that was left untreated. And so that really kicked into high gear when she had her second baby, born at 34 weeks, and had another NICU stay. And then that's when she knew that something wasn't right and she needed help. But she kept finding that there was very little help for PMADs at the time, and definitely none for NICU families. Um, and so that is really what led her to found Hand to Hold. Next slide, please. And to tell you a little bit about myself, I am the program director at Hand to Hold, and I joined after my own NICU experience. I went into labor unexpectedly at 24 weeks gestation, and I had a short stay in the antepartum wing there at the hospital. And then my daughter was born at 26 weeks, and she weighed just over 2 pounds. Until that moment, I had worked in maternal and child health at different nonprofits at the state level. That was my background, my education focused on that, but neither my education or my work experience prepared me for the NICU journey. It was completely unexpected and eye-opening, to say the least. But also being Mexican American, I intimately understand many of the challenges that families of color can experience when it comes to identifying the need for support and then seeking that support. And so it's part of my personal mission to ensure that we have accessible and equitable services. Next slide, please. So here are a few more stats. We know that 1 in 7 babies spend time in the NICU, and the majority of them are born unexpectedly to parents. You know, they didn't know that was going to happen. Nearly half of them are full term and the other half are preterm, but in all the different scenarios, it causes distress to the parent. And then we also know that NICU parents over-index on PMEDs, meaning that it's much more prevalent when you have a NICU experience, up to 20 to 30% more. And then we know that Black and Hispanic women are disproportionately affected, as Dr. Lloyd shared, and more likely to experience postpartum depressive symptoms. Next slide, please. And so we know the NICU is hard. That is something that everyone at Hand to Hold who has experienced the NICU knows, and it's what we hear from parents. It is hard. And so we believe, and research shows, that the care for the parent is care for the baby. And when we're help care for the parents and provide that early intervention, benefits are that we can reduce their isolation, increase their confidence, and really support that bonding, which is important for the babies to have a good start. Next slide, please. And so at Hand to Hold, we use evidence-based peer support to help mitigate the negative impact of a NICU stay. Here you'll see the 4 pillars that our work really is based on. We believe it's important to have that personalized support for moms and dads. As Dr. Lloyd mentioned, dads are affected as well, and we have a family fatherhood support specialist to provide that unique care. So support for moms, dads, and bereaved parents, and it's all free of charge. Currently, we have services in English and Spanish. And then it's also important to have that consistent quality of care, whether the services are in person or virtual. And then the last thing really is that the services are offered by people who have lived experience as NICU and or bereaved parents, but they're also trained as mental health peer specialists. And that's important, to receive that certification and that training to really know how to properly work with families and ensure that We're there to help and not re-trigger an already intense situation for parents. Next slide, please. And so here on this slide, as part of what we do, you can see our reach for our virtual services. We're reaching families in 48 states. And then for in-person, these are the hospital systems that we're currently partnering with. Next slide. And so on this slide, I like the little visuals. These are the services that we actually provide in our hospitals, such as Dell. We are really integrated into the care team, and we call it rounding, right? Just like the doctors do. We stop by every bedside, whether mom or dad or grandma, whoever's there with the baby. We stop by and connect with them, really engage the parent to see how they are and asking them how they're doing and following up with them throughout their stay. So it's that one-on-one bedside support. We also have support groups weekly, and we have educational resources. And some of these, we have handbooks on navigating the NICU itself, because it's a whole new environment that you're having to learn in a very high stress situation. And then we have other resources for beyond the NICU, right? So when they're discharged, and specific ones for our bereaved families. And we also think it's important to have special events to celebrate milestones and wins in the NICU, because it is very hard. And so sometimes it's hard to see, those little victories. It's also very difficult for some parents to see themselves as parents, to see themselves as moms or dads. So some of our special events include things like Mother's Day and Father's Day. And you'll see here the bottom layer, which shows our virtual support. You'll see that they mirror our in-person ones, and that's intentional, because we really value that consistency in the care that we're providing, and we want to be able to, whether we're connecting with you in person or virtually, that you're getting that consistent quality care. And so again, we have one-on-ones. It's not at the bedside. It is through a platform like this, like Zoom. And then we have virtual support groups as well. Our resources are provided digitally, and then we have digital communities. So we have Facebook groups, and we just launched a new app, and happy to say we have over 500 folks within the first month of launch. And so families are really connecting within those forums. Next slide, please. So here, this pyramid was developed by Dr. Richard Shaw from Stanford, who we partner with. And it's a nice visual that illustrates mental health interventions that are needed by NICU parents. And so you'll see that they begin broadly at the bottom, that we should have that universal screening, that there should be opportunities for developmental care and mentoring. And as you go up in the pyramid, the different tiers, they become more intense, right up till tier 4, where parents may need medications. And so we are able to provide, through the different services, programming that fits into tier 1 to tier 2 and 3. None of it is prescriptive. Parents get to choose, I want to go to group. I would like to have a one-on-one. Obviously, like, we do round and stop by, but if someone doesn't want to engage, that's fine. We'll check on you later, and they can engage in one service or all services, and we very much encourage that. Next slide, please. And so our team, excuse me, we refer to our employees as family support specialists. As I mentioned, they go through an intense certification to become mental health peer specialists. But here in the middle, I just wanted to highlight a few of the trainings, the topics that they receive in addition to really have that broad education and work with the families as best as possible. Next slide, please. Oh, next slide. Yeah. And so really, in addition to the services and with us connecting with the parents, one of the things that's really important for us is that our services are really led by the parent of today, and what does that mean? You might be thinking. So, you know, um, parents currently in their 20s that are having babies, new first-time parents are in their 20s, and that is a different generation than most of my team and most of the nursing staff, who might be millennials or Gen X. And so really staying focused on what are these newer generations needing, how do they engage, what connects with them, and making sure that we're reaching them in those ways. But really here in the little box, highlighting that partnering with us, really the feedback that we're getting with families is that um, 98% of them feel better as a NICU parent once they come to a session, once they come to a group, and they feel more confident. And in addition, you'll see that 97% of NICU professionals say that they can see, or they feel, they believe that NICU parents are more confident after they come and engage with us and participate in our services. Next slide, please. For time's sake, I think I'll also gloss over this since I already talked more about what our services are. Next slide. And here, just highlighting some data points that we feel is really important. It's not only important that our services are impactful to the parents, it has a trickle effect to the baby, right? Because there's increased opportunities for bonding. But one of the things we discovered as well as we've been working with hospitals is that the staff also feel that impact. And so you'll see here, 93% of supervisors and managers agree that having us there allows them and their staff to focus more time on caring for the baby. Before we showed up, they were taking care of the baby, but also could see mom or dad in distress and, felt the need to engage with them, but they often didn't know how. And it was taking time and care away from the baby. Now we're there and we're able to provide that. And it's wonderful to see this feedback that they're feeling that we're helping them save time. They're focusing on the baby, and then that they're balancing that patient care and family support. Next slide, please. So what I've talked about so far is our in-person, but we also do reach families virtually. And so here is some stats from them, right, that they feel more hopeful by attending our groups. 95% feel less alone in their journey after they engage with us. And I did want to read here this comment from Lindsay. She says, Hand to Hold provided a free support group for Black families, a resource list of counselors in my state, and taught me the difference between baby blues and postpartum depression and taught me how to advocate for my daughter. And this is really important because she mentions, a group specifically for Black NICU families. And that is one of the ways that we're trying to be equitable and accessible for families. We know that having that culturally congruent and competent care and a safe space is essential for this population. It's also why we have the Spanish language groups for our Hispanic families, why we have dad-specific groups. We're really trying to meet the needs of families. One of the things I also wanted to mention was that one of the ways we're also trying to do this is really through our team, we want it to be reflective of the populations that we're serving. And so 70% of the direct staff are people of color, identify as two or more races, and then 75% of the team speaks two or more languages. So really trying to meet the parents where they're at. Next slide, please. So I'll mention here very briefly, we launched our app and it's free to parents. This is important to us because we know that 98% of people have a smartphone. So it's something accessible that they can a way that they can get support. And it also frees us up from some of the social media algorithms, and so we can really truly connect with families. I also want to mention this because it is one of the ways we're hoping to scale our program, our virtual programming, to partner with more hospitals. We're currently piloting a program to offer this app. The app will always be free to families, but when we partner with a hospital, they will pay for a few extra items that are going to be specific for their NICU, for their hospital, such as having a specific support group for those families. Next slide, please. I think I came to the end here. Sure. And so if you want to know more, you can go to our website and fill out a proposal, and we can chat. I will leave with this. I know one of the challenges that we've encountered in trying to partner with hospitals is the partnership with the hospital. We do have a fee, and often what we're seeing is that many of the decision makers don't quite understand, and I'm talking about like the C-suite executives who may say, why would we provide care or pay for services for the parent when patient is the baby? And I understand that line of thinking, right? On paper, you're thinking the patient is the baby, but that's when it's important to highlight some of those stats that's saying it is helping their staff members care for the baby, it's saving time, but also that care for the parent is care for the baby. And that's when it's key to have support, not only from the NICU staff, which they understand and they see the value, but people like Dr. Lloyd, who are medical directors or who are at those tables that can say, this is something that's really needed and it's going to benefit our patients. And I think that's my last slide there. Yeah. So hand it over to Jill. Thank you.
Hi, everybody. My name is Jill Kottmeyer, and I am the Director of Wellbeing and Bereavement at Northwest Community Hospital. I have been working in the perinatal loss space for about 25 years. I started out as a labor and delivery nurse and was very involved with those families. And then I continued on and became the perinatal palliative and bereavement care coordinator before moving into my current role. So my heart and soul lives in this space and with all the families we've impacted. Next slide. So what I'm most proud of is that we've had an established bereavement support program that has evolved since 1990. So we have patients and families we've been working with for years and years and years. We do have a current coordinator that supports labor and delivery, NICU, and postpartum. She provides one-on-one support while they're here for their stay, and then follow up for about a year. We'll get into a couple of these things later, but we also run a pregnancy and infant loss support group, pregnancy and parenting after loss group, and then we have 2 memorial services a year where those families can come back to the hospital and connect with each other and remember and honor their babies with their other families. We also send out a monthly newsletter as another touch point of connections for families. And then we also have a staff training and in-services, and that goes throughout the hospital, from our ED to our NICU, labor and delivery, postpartum, our OR, and our day surgery for our earlier losses. One of the most important things is having staff on board and staff trained to care for these families. We can't just assume that our staff know how to be present for families after their child has died. So we really, really focus on the importance. All of our staff in Women and Children's Services go through a mandatory education. It's an 8-hour education on supporting families through perinatal loss. And I think that's essential when you are building a support system within the hospital and you are caring for these very, very delicate families. In addition to that, during COVID, we developed a crisis response team, and that is called the RISE team. It stands for Resilience in Stressful Events. We understand that these challenging times and challenging patients and families and grief that our providers feel after caring for these families, really, they also need the support too. Next slide. So we have just a few pictures here. The two on the left are from our butterfly release, and that is one of our memorial gardens that we created back in 2009. And that was funded through our community and our foundation. And that's where we host our annual butterfly release. And then on the right is some photos from our Walk to Remember that happens during October, because October is Pregnancy and Infant Loss Awareness Month. You can see families bring their living children and they participate, and it's really a time to enjoy each other and connect with each other and then remember their children. And then in the middle is something called a Jane's Room. If anybody has ever heard about the Jane's Room Foundation, they build bereavement spaces throughout hospitals in the United States, specifically designated for perinatal loss. So whether that loss happens in labor, delivery, postpartum, or the NICU, these are waiting rooms where families can spend their time together and not in other spaces where people are maybe having more of a joyous birthing experience. And we converted one of our patient rooms and dedicated this in 2019, and it has just become an integral part of the bereavement care that we provide for our families. Next slide. When looking back over the past 30-ish years, this really was a grassroots movement when, in the 80s, we started learning and realizing that the bereavement care of taking people's babies away, not allowing them to see them or hold them or bond with them, was actually not good for them. One of our labor and delivery nurses started doing some of that research and saying, we need support here. So she started doing just little things throughout the unit and supporting families, educating others, bringing mementos in, talking about taking pictures. So it really began on the ground by a labor and delivery nurse, and it grew into this very rooted program in our hospital and in our community. We have a vast amount of people that attend our support services who did not deliver their baby here. Again, it started in labor and delivery, moved to the NICU, and then expanded to our other areas because our earlier loss patients were needing that support. One of the other things I really like to talk about over the past probably 6 years is this focus on perinatal palliative care. And if you're not familiar with that term, you may have also heard perinatal hospice. But this is the care that Dr. Lloyd kind of talked about when somebody gets a life-limiting diagnosis. How are we providing care for them? And our model here at the hospital is we have immediate connection with that family from the time of diagnosis. And we provide support throughout their pregnancy, provide anticipatory guidance, give them options for what they want. Some families opt for termination. Other families will opt to continue that pregnancy. And at birth, some will opt for a lot of intervention, and some will opt for comfort care. And our staff and our coordinator is there to provide that support throughout their journey. And then that continues on afterwards. It's just an extra layer of support, no matter what the outcome is. Next slide. So in speaking specifically to our NICU, I want to point out that this is a very sacred space of pain and grief and a lot of emotion for families and a lot of vulnerability. And we are there to support them in their darkest hours. And it's not something I or anybody else providing this bereavement care take lightly. So our bereavement support in the NICU kind of evolved once we started providing support in labor and delivery. And it has evolved throughout the years. But when I took over that role, I noticed that I would be called in when a baby died, and I would come in and meet these families, and I would be like, hi, my name is Jill. And then I'd tell them all these things that they felt were somewhat shocking, right? We're going to hold your baby, we're going to bathe your baby, we're going to do footprints and molds and really try and create these memories. And I found it very challenging not having a relationship with these families prior. So we changed things up, and I would start consulting these patients when they came in, let's say with a ruptured bag of water at 23 weeks, and we knew that they were going to deliver and be in the NICU. You can see the other list of things that I would be consulted on, but it was really about establishing that relationship as early as possible. So if something did happen and that baby did die, we would have that trust and that bond already when I would provide that bereavement care. And like I mentioned before, that added layer of support no matter the outcome. So some of these families I would follow through their NICU stay and through discharge and provide that extra layer of support. And then other families, it would be the outcome of death, and I would provide that support throughout that journey too. Next slide. When we're talking about key stakeholders and supporting these programs, staff, you have to have the buy-in of the staff, or else it's not going to continue on. The directors and the leaders in the C-suite, our foundation has been very integral into everything that we provide here. The community donates a lot of stuff, and then we have other generous donors, and then a ton of previous patients and families. You see me pictured here with the leader of the Weston's Fund, and they had a loss around 15 weeks, and his name was Weston. And she came to me a year later and she said, when I got my hospital bill, it was the most triggering thing that could have happened. So I want to help families pay their hospital bills. So she worked with our foundation, and now we have that additional resource for families. So they don't get as much hospital bill, and it takes some of that pressure off of the families. Next slide. So many programs start with very limited budgets and resources, and it's really important to focus on those small implementations you can make that just keep adding and adding and adding. You can build on each success every year. I know a lot of times people want to just be like at the end and have this big program, but if you start small and continue engaging your community and your foundation and your stakeholders, you can continue to grow. There's a list of organizations here that either provide resources for families, mementos for families, education for staff, and those are really good to tap into because that's going to decrease the budget that you need. And engage previous parents. One of the most beautiful things that I am able to witness in this work is seeing people in their darkest moments and their deepest grief, and then moving forward and really trying to channel that grief and do something amazing, just like with Hand to Hold. Kelly went through this experience and then made something beautiful out of that. And we see that with so many of our patients and families. And then again, if you have a hospital foundation that can help support your initiatives, that's another great resource. Next slide. So when I worked on changing our approach and not just stepping into that space once the baby had died and really developing that trust and that relationship, I saw our relationships develop. The trust was so much deeper. And really what we want in the end is that families are guided through their grief from the time of diagnosis to the end of their hospital stay. And we really want to focus on building that therapeutic relationship with not only the nurses and supporting the nurses, supporting the families, the extended family, and really honoring that child's life no matter how short it is. We often provide those, we always provide those resources upon discharge, and then bring those families back who are open to support groups and create those connections and maintain those connections. We bring them back for the memorial services as another touch point. And I think the true test is how many patients want to come back here and deliver another baby, even though their baby has died here, because they had that foundational support. I want to speak a little bit to this family here. They're always in my heart, and their baby's name was Journey, and or is Journey. And they were this baby had an anoxic brain injury, and they were a black family, and Daryl, the dad, he had a lot of mistrust with the healthcare system. And when I first met him, he said, my aunt told me either they're trying to kill you or they're going to kill you. And she had been a nurse. So there was a lot of walls up with Daryl, and we had to break down a ton of them, especially because we knew that his son was going to die. So we spent lots of days together, lots of time building our relationship throughout this journey. And it was one of the most beautiful relationships I've ever been able to create because of where he came from in the beginning. And then to after their son died and him hugging and crying in my arms at the end, I knew that we had made an impact, and we met him where he was at. We could not change his belief system, but we could support him through that without judgment. Next slide. So one of the beautiful things about this work is there's always room to grow, always room to evolve and improve the work that we're doing. We don't focus a lot on data and metrics, but I think that's definitely an area of improvement. I think we need to continue to understand various cultural needs of support. When we look at our support group, it is probably about 50–60% white. We do have some Hispanic families, some Indian families, and maybe a few Black families trickle in. So asking ourselves why that is, are people not comfortable in those spaces? And if they're not comfortable in those spaces, how can we get them the support where they do feel comfortable? So in the last couple of years, we've partnered with Star Legacy Foundation because they have a Spanish speaking support group. We also refer some of our Black families out to Sisters in Loss if they feel more comfortable in that space. So if we are not providing the spaces, how can we connect these families to the spaces that they need for themselves? I think COVID highlighted a lot of things for me personally here and the support that's needed. There were a lot of challenges. It's very challenging to provide bereavement support when initially you're told you can't touch somebody, everybody has to wear a mask. It's very hard to grieve in those spaces. A lot of services dropped off for these families, and we and our hospital chose to continue. We had to alter and adjust and work with this new virtual world, but we've made beautiful things out of it. And I think at the end of the day, the most important things are we need to meet people where they're at. I have said that, our other speakers have said that, and step out of judgment. It is not our journey, it is their journey. We are here to witness that and accompany them through that. It is so important to honor culture and faith and understand that not everybody's going to be receptive to the bereavement care. And it doesn't mean you're doing something wrong. And it doesn't mean they're not grieving. They just have different needs, and we need to honor all of those needs. Next slide. I think one of the most amazing things is in these support roles for bereavement care is that relationship that we create with ourselves, with our patients, with our families, with their babies. I know that I learned something from each family. Our families are our greatest teachers, and I take that learning to each new family, and that's how I believe I am honoring that child's life, is taking that education and learning to that next family to impact them in that way. And I think when you look at this across the continuum, it's really creating a circle of trust and relationship and accompaniment. And it's all tied together. One thing that we did also find out during COVID is that pregnancy after loss is a significant challenge for families. And that's why we created our pregnancy and parenting after loss group, because there were so many people that were getting pregnant again, and their anxiety and worry was just through the roof. And they needed just as much support as they did in the beginning of their early grief. And again, just continuing that circle and meeting them back if they did choose to have another baby after their child died, and providing that support and continuing that on. Thank you, everybody, so much for being here and listening. And thank you to Dr. Lloyd and Rachel for your amazing work that you guys are continuing to do also.
Thank you so much, Dr. Lloyd, Rachel, and Jill, for sharing the great work that you're doing and also your personal stories and the stories of your patients. I know that's not easy to share, so thank you so much for doing that. And I appreciate your honest and openness in this conversation. So with that, I want to turn it over. I know we have a couple minutes left, so I want to open up the session and see if there are any questions from our participants. I do believe we have one question for Rachel in the chat. How do hospitals you work with typically pay for hand-to-hold services? Rachel?
Sure. None of them pay for it the same way. And I will say, I'll start by sharing, I know this also comes up, is, how much do we have to pay? And unfortunately, there isn't like a standard fee. It's really based on like the number of admits and all the services that we're providing. So that's where a conversation about your hospital and the needs that we're trying to meet is really important. But I would say probably 3 or 4 of the 6 hospitals they work with make it a line item in their budget. I don't know what that planning is like for them on their end, where but somehow they managed to carve it out. And then others work closely with their hospital foundations. One in particular I know held like a fundraising event specifically to bring the program. Another one, the foundation just cut a check, which was very nice. And then, so it can depend on with your foundation. I know with the current pilot that we're trying to do with the virtual programming, a grant was written to cover that initial fee and really be able to note our findings and that sort of thing. And then some ways that other hospitals who purchase our resources, like our handbooks or our milestone beads, it's really through fundraising efforts from parents. So the PFAC, so like the patient or family advisory councils, or whatever it might be called in the hospitals, fundraise to get resources into their NICU, into their hospitals. They I think often do things like that, and maybe they get the rockers or the recliners, and so this is for them, it feels very natural. I know currently we're exploring ways to how can that be broadened if they want to bring us to partner with them. So a variety of ways.
Thank you. Any other questions? Feel free to chat those in for our speakers. I had a question for Dr. Lloyd. I know that your partnership with Hand to Hold started in 2021. What are some of the early wins that you've been seeing since that partnership?
Yeah, so we started in 2017 at
2017.
Seton, and then 2021 at Dell. We a fundraising pads up thing to get the few years funded at Seton, but we've seen such positive feedback from our families that it's now a line item as part of the hospital. So we've seen an improvement in our patient satisfaction scores. We've seen an improvement in our patient engagement. We would consistently get questions from one hospital to the other when they would be transferred, and it was not there. So it is something that we've seen tremendous positive feedback from our families on.
Thank you. And to see if there are other questions.
And just, although we're waiting for that, just to add, I mean, as we've talked about this, there's so much literature that supports which isn't surprising to any of us that have children, that the home environment that you put the baby into impacts their long-term developmental outcome. And so the things that we can do to improve mental health of mothers and fathers and create more stable environments for our babies to go home to is something that will bear dividends for us as a community for generations to come.
Totally agree. Rachel, Jill, any thoughts from you all? Just any last takeaways, anything that you would want our audience to know about such programs or about the work that you're doing?
I think I'd just like to add that, we all know the state of hospitals right now, and a lot of time these support services and support roles are getting cut and thinner and thinner and thinner. So continuing to advocate and engage your C-suite leadership on the impact of these support programs is essential. We have either our CEO or our COO attend all of our memorial services. And they do so willingly. They want to be there and they want to be present, which we are very, very lucky to have. But I think it gives them a perspective, right? Our program is not revenue generating. And in the times that are going on right now, they're looking at revenue generating programs, but they see the impact it has on the community. And being a community hospital, they value that impact. So I think it's really important to continue engaging our senior leadership in the importance of this for our parents, for our families, and for our communities.
Very well said.
Yeah.
I will state, piggyback off of that is that I think initially, because we had the buy-in from NICU directors and they saw the work and we had some feedback that was great, but like you said, things are getting tighter, they're getting harder. And so really, then that's when we really focus on trying to get more of that data to be able to show, to paint the picture in more ways than one, right? And to be able to speak to the different levels of leadership. And I think one thing that came to mind was just, but Jill, you mentioned something like this, that you need buy-in from the staff. And, when we come to a hospital, it's like, they don't know who we are. There's lots of questions from the staff, like, especially like the night shift who may not see us right away, like as we're, building out schedules and that sort of thing. Like, who are you? And are you trained in HIPAA? And can I tell you things, and, because they were new, right? And they need to know, they need to trust us. And so we're building relationships, not only with the families, but with the staff, and that could not be shown anymore other than like when COVID happened and everything shut down and we were out of the hospitals for about a month. But it was incredible to see how our partner hospitals said, like, you need to come back, right? And made it a priority to get us back in because they really saw how impactful it was to parents. Also, it was so challenging for parents, right? Many hospitals, you could only have one parent at a time or one visit a day, or, everything was just so much more challenging. And that we just felt very thankful, that they valued us and that they advocated for us to come back in. And I think really having that solid partnership was beneficial, and that we weren't just, and I don't want this to sound indelicate because we value volunteers. We have volunteers, but that we were like a partner, right? That they're like, because, and I say that because some of our hospitals like banned all volunteers, and it was like, right, like you didn't see anyone that didn't need to be there, and they really fought for us to be there, and we were back within 4 to 6 weeks at the earliest for some. At the latest, I think it was maybe 3 months was the last one that we struggled with. But we were there every day, part of the care team, and that really meant a lot to the families, and it meant a lot to us to have those relationships. And and to have them ask us to be there again.
Thank you for sharing that, Rachel. We have 5 minutes left. I had one other question for all of you, is that what we're seeing at times is that that perinatal visits, those are very important, obviously. Are these services communicated to the patients that are coming in for these visits, so that they're aware that this, they have something, if anything happens, that they have these services to kind of rely on? How does that fit into the perinatal visits piece?
So speaking in the bereavement space or palliative care space, it's a work in progress. In the ideal world, it's given to them. All of our doctors are educated on it. Some are more open, and they'll text me and be like, I have this patient sitting in my office, we need you, but others aren't as forthcoming. So that's a continual work in progress, and we still need to improve that. Somebody just asked a question.
Right.
Okay, so talking about how we approach families with life-limiting conditions early on. So typically they're with their provider or they're with our maternal fetal medicine. And it is, so our role of that extra layer of support is introduced to them. And then we will have our initial care conference that typically has their OB, their MFM, our social worker, myself, possibly a pharmacist, our neonatologist. And we really sit down with that family and talk through the diagnosis, what's that like for them, what their hopes and dreams are for their baby. And then I continue that relationship. We kind of meet depending on their needs with the interdisciplinary team, but the majority of that relationship in between is the coordinator and them kind of working through their birth plan and what the important things are for their child and their family and what they want to focus on.
Thanks, Joe. Dr. Boyd, any thoughts?
I was going to say, well, that's just going to look very different from facility to facility. And they're very fortunate to have resources. We have a whole palliative care program that fits into this space. And so if someone's diagnosed with a life-limiting condition, we meet that family there. Some families continue, as has been stated, with very aggressive medical interventions. Others choose very, very limited or no medical interventions, and some somewhere in between. And we have designated navigators that help walk that family through that process, where they're meeting with subspecialists, they're meeting with nursing staff, case management, social worker, pastoral services, really depending on what elements that they want, so that there's a tailoring of that journey for each family, so that we can help walk with them along a path that they determine that's going to be best for their family and best for their best for their family. So I think our job is to try and assess, figure out where they are, and then in whatever community you're in, whatever environment you're in, try and figure out what things can you bring to bear to help support this family through this process that begins sometimes before birth, sometimes right at birth, sometimes even weeks after birth, to help the grieving families.
I think if I could just add one thing, John, that's great. I'm thrilled that you guys are doing that and you have a huge team. Sometimes it feels like a team of one over here because we're a smaller hospital. But I think it's important also to not, I think in medicine, sometimes we live by statistics and probability. We recently had a family, their baby, Anna, had trisomy 18. And she wanted fetal monitoring, and the maternal fetal medicine doctor did not agree with that and made it very vocal. And they had every intention of bringing their baby home. And he said, they're never going to bring this baby home. And they brought Anna home, and she lived for 6 days. And they had 6 days at home with her. So there's statistics, and then there's the reality that we can't predict everything. And I think that's really important, especially with those cases.
Oh, I couldn't agree more. I've got a 14-year-old trisomy 18 in one of our neurology clinics. So we have to meet each family where they are, listen to them, and then help them walk their journey, not predict or project upon them what we would do if we were in their situation, which is, I think, foolhardy for any of us to try and do.
Yeah. Thank you so much, Jill, Rachel, and Dr. Lloyd, for sharing all the work that you're doing and those recommendations. I just wanted to also share that the AHA has a webpage with a bunch of resources that you can use to advance the work that you're doing in the maternal and child health space. Link is on this slide, so feel free to check that out. And again, thank you to all of you for attending. And if you have any questions, feel free to contact me. And I hope you have a great time at the rest of the conference. Thank you, everyone.
Thank you very much.
Thank you.
All right. Good afternoon, ladies. Thank you so much for joining us.
Hi, good afternoon.
Hey, how are you?
Good.
Welcome.
How are you? How are you?
Good. Good. Good.
My audio coming through okay?
Yeah. You sound great.
Good. I was working out the AirPods while the other session was still going on. So glad to know it.
Got it. Got it. Yeah. Should be all good. Right. So does everybody feel comfortable and know what kind of the run is? I think actually you've done this before. Jamie, you probably too. I can't remember if you did this last year or not, right?
Yep.
Awesome. Yeah. Okay, beautiful. So this session is not going to be recorded, so you won't have to worry about that. And I'll keep tabs on how many people we have attend, how many attendees. Otherwise, I think we're good. I'll give you the 5-minute warning once we get there. And other than that, do you have any questions for me? No,
I don't think so.
No.
perfect.
No,
All right,
we're
well, I'm
good.
here. I'm going to go off camera and off mic,
Okay.
but I'm here watching, listening, and I'm just going to check my final reminders here to see if there's anything else I need to say. But otherwise, we can get started when we're ready.
All right. Hi,
Stacey.
Katie. Hi, Katie Breen.
Katie. Are you automatically muted?
There we go. Sorry, I just realized my volume was turned all the way off. So if you said anything before Stacy said hello, I didn't hear you.
It's good to see you.
Yeah, you too. Elena is with me here in person.
Oh,
Hi, Elena.
Hi,
She
Elena.
went to the bathroom. Yeah.
Okay. We'll just do it again when she comes.
Yeah, we'll just keep saying hello.
How is everyone else out there?
It's like we have some joining for this session and a few dropping off. Let's see.
Yeah, and Aisha, Jamie, and Stacy, I'm gonna spotlight all three of you so that.
Okay, I was wondering why I saw myself so
Yeah, just
so large.
there we go.
And I think I'm gonna follow suit with Aisha.
Perfect.
All right, I'm gonna pop up my slide deck if that's okay with everybody. Share my screen. Just so folks know the session they're entering, and then I can pull it back down when we do intros. Does that sound good?
Sure.
Yeah.
Like we have folks still joining, so just want to welcome everybody. We'll get started here in just another moment. This is the PQC, Perinatal Quality Collaborative Maternal Mental Health Networking session. So welcome, and again, we'll get started in just another moment here. All right, looks like we have a number of folks that joined. We're just at about 1 minute after the hour, going on 2. So let's go ahead and kick things off. I am just so excited to be here, welcoming all of you to the Perinatal Quality Collaborative, or PQC, Maternal Mental Health Networking session. We're so excited at 2020 Mom to have you all joining us throughout the forum. Hopefully everyone's been joining a number of sessions and learning a lot and being able to connect with colleagues in the space from across the nation and even internationally. My name is Jamie Cabrera. I happen to be a 2020 Mom Board of Directors member. I've been on the board for about 2.5 years, and I also serve as the treasurer of the board. So really thrilled to have you all here. My background is actually somewhat in PQCs. I worked with the Colorado PQC for a number of years before moving to Dallas, Texas, and now working at an organization called Girls Inc. And a really nice linkage and actually some shift in preventative teenage pregnancy is a lot of our focus, working on primarily delivering programs and services and access to resources for girls that live in low-income households and in communities of color. And we do really inspire them to be healthy, make healthy choices and decisions about their body, and have information necessary to not engage in risky behaviors and ultimately prevent teen pregnancy. So I'm really excited to continue my work for advocating in the women and girls space, and excited to talk more with all of you here about your work specific to maternal mental health in your states. I am going to introduce my colleagues and co-facilitators, and then we'll do some introductions for those of you on the line so that we know who's here, who we're networking with, and who we're sharing information, can continue this conversation, hopefully make some connections, share email addresses, phone numbers, and really make some contacts and continue this discussion and collaboration after today's session. So with that, I'd love to introduce you to Stacy Penny, and Stacy is the Senior Project Director at the National Institute for Children's Health Quality, or as many of you know, NICU. And then Aisha Sayada, who is our Senior Program Manager with the American Hospital Association. So hello, Stacy and Aisha. They'll get more time to tell you a little bit about themselves and their role with their organizations in just a few moments. What we'd like to do now, I'm going to check, since I'm sharing my screen, I can't see everybody, but I think we have enough time for you all to pop off your block on your camera. So turn on your video, give us a quick hello, state your name, the organization you're with, and maybe something interesting about your work. That will help us to really kind of think about the discussion, who's here to have some conversation about maternal mental health and their PQCs, and we'll really kick things off. So I'm going to go ahead and call out some names, if that's okay with everybody. And I'll do first and last. If I mispronounce, please correct me, but we'll go ahead and start our round robin introductions. I see Debbie Levin. So we'll go ahead and start with you, Debbie.
Hello, thank you so much. So I am a social worker at Memorial Hermann Southwest Hospital. So we are the largest hospital system in Houston. I'm a perinatal social worker, so I cover labor and delivery, antepartum, postpartum, regular newborn nursery. I've been a social worker for over 30 years, working with either in the capacity of working in pediatrics or mother baby. And I partnered a lot with quality. We started doing the Edinburgh Postnatal Depression Scale 2.5 years ago, throughout our system, and that generates consults. And that is where I come in to assess, to do a complete psychosocial assessment, offer resources and link. I do warm handoffs and linkage to care. Our population is probably half Hispanic, a lot of recent immigrants from Central America, and we have some refugees. It's just a very diverse population, mostly unfunded, or they have CHIP perinatal or Medicaid. They're going to lose their coverage, and there's just a real shortage, as you all know, of mental health services out there for these women, especially specializing in perinatal mood disorders.
Wonderful. Thanks for sharing, Debbie. Welcome. Kelly Persanti. I understand that some folks might be not able to come off audio or on camera. So if you're not able to do that, we'll kind of skip to the next person, and then we can continue on, and feel free to pop something in chat and let us know who you are, where you're from, and maybe a little bit more about your role. Elena Aronen.
Hi there, I'm Alana Aronen. I'm in the Child Health Advocacy Institute at Children's National Hospital, and kind of considering all of the overlapping issues around perinatal mental health in the pediatric setting. We know that I love the statistic yesterday was spot on, that where we lose a lot of women for their postpartum care for themselves. We know that 98% of caregivers still make those pediatric appointments, and we do see and we screen for it through all of the different entry points into the pediatric settings through Children's National, and just looking to branch into as many of the resources as possible to strengthen both what we can do at Children's National, as well as support what's going on across the whole community in DC. Thanks.
Wonderful, thank you. Marisol Flores. All right, how about our Katie and the Colorado PQC? Can see you all there.
Hello, I am Katie Breen. I'm Elena. And we are with the Colorado Perinatal Care Quality Collaborative. And yeah, we work on a lot of statewide initiatives related to maternal mental health. So both in a hospital clinical quality improvement setting, as well as across the broader spectrum of maternal mental health workforce and sort of stakeholders and advocates. So community members, outpatient, maternal mental health providers, and the grand spectrum of public health agencies that focus on maternal mental health.
Wonderful, thank you. Myra.
Hi, my name is Myra. I'm a family support specialist with home visitation program here in Long Beach. I'm actually located in the hospital. Um, I do home visits for new moms. I screen them for I screen the PHQ-9s. Sorry, I screen the PHQ-9s, GAD-7s, ASQs. So I'm a home visitor.
Great.
Thank you.
Thank you. Unit. All right. Kelly.
Hi, everyone. My name is Callie Rowland. I'm a project manager with NICU and the NMPQC. So I work closely with Stacey Penny. I feel lucky enough to get to interact with PQCs almost every day and learn about what they're doing and provide support where I can. So it's nice to see you all.
Thanks, Callie. Bonnie.
Hi everyone, I'm Bonnie. I'm with Baby Scripts. I do product here. We are a digital health company, and a part of our product is related to screening for behavioral health during the pregnancy and postpartum space. So,
Thanks.
Yeah.
Allison.
Hi all, my name is Allison Kite. I am here representing the Riley Group, which is a public affairs firm that works with Postpartum Support International to run the Mind the Gap initiative, which is a national coalition devoted to making perinatal mental health a national priority. And we also have a state level policy series where we use a evidence-informed process called PACE to work with state teams to set goals and make policy change happen in their states. We often partner with PQCs, or PQCs are our backbone organizations for that series. So really looking forward to learning from all of you and hearing more about what you do.
Great, thank you. Jennifer.
Hi, I'm Jennifer from Square Care. So I am population health manager and a care manager for Square Care. I care manage high-risk patients that go through behavioral health, postpartum depression, anxiety, all the things, and I connect them to behavioral health services. I stay with them until they're connected, and once they're connected to what they need, I discharge on my end, but we make sure that they have support all the way through until they're stable.
Great, thank you, Jennifer. Tiffany.
Hi, everyone. Good afternoon. My name is Tiffany Lenz. I am the perinatal clinical nurse specialist, nurse educator at UC San Diego Health in Southern California. So I work with a high-risk inpatient population, but I'm actually finishing up my doctorate, and my work has been in perinatal mental health, particularly in depression screening. And so my goal is to work with the California Maternity Quality Care Collaborative, or CMQCC. We are a CMQCC hospital. We do a lot of data reporting out to them, but to work with them collaboratively to work on a toolkit related to maternal mental health.
Great, thanks, Tiffany. Emily.
Hello, my name is Emily Brown. I am the State Government Affairs Specialist at AAMFT, which stands for the American Association for Marriage and Family Therapy. And perinatal mental health isn't something we've focused on in the past. So I'm here to look for more ways to see how AAMFT can get involved. And I'm so happy to be here.
Great, thank you. Susan.
Hey, good afternoon. My name is Susan Ford. I'm a quality improvement specialist with the Ohio Perinatal Quality Collaborative. My training is it passed as a maternal child nurse for a number of years, but I've been with OPQC probably for the last 10 or 11 years. My focus has been on opioid-related projects, and our current project is maternal infant diet in the context of OUD for that first year postpartum. And so there's really a need for a lot of perinatal mental health support in this vulnerable population. And so I'm really looking forward to learning more today. Thank you.
Thank you. And we have another Katie Brathfield.
Hi, I'm Katie Brassfield. I am the project manager of the Missouri Perinatal Quality Collaborative. I have been a labor and delivery nurse for 15 plus years, so I'm new to the public health sphere, but we are currently implementing 3 of the AIM bundles in Missouri and really focused on substance use disorder currently, and planning to implement the perinatal mental health bundle in the coming year. So I'm excited to learn from everybody today. Thank you.
Thank you. And I think one more, Kelly Persanti. All right. Well, if I missed anybody or anybody's just joining us that missed the opportunity to do an introduction, feel free to use the chat function and type in your name, your role, where you're from. And with that, we will go ahead and get things started. And I will hand the next topic off to Aisha to introduce us to what we hope to accomplish during today's session.
Thanks so much, Jamie. Sorry. Hi, everyone. My name is Aisha Said. I'm a senior program manager at the American Hospital Association. And at the AHA, we have maternal and child health is a big priority for us. So we have an initiative where we're trying to create resources, thought leadership, and share evidence-based practices on what hospitals can do to improve outcomes for moms and babies, and maternal mental health is a huge piece of that. So we recently launched a webpage with a few resources that hospitals and others can use to really start the conversation and see what other organizations are doing around maternal mental health. So today we are hoping to understand the work of perinatal quality collaboratives, the challenges and the opportunities that they have in improving maternal mental health outcomes, and really understanding what we all need to enable us to do the work that we're doing in this in the space of maternal mental health. So we're looking forward to having that discussion with all of you, learning from the work that you're doing, and then hopefully finding ways that we can kind of all maybe work together or work with one another and form those collaborations and have those discussions to really make a bigger impact. So excited to kind of have those conversations today. With that, I want to turn it over to Stacy to introduce herself and then kind of just lay out the foundation of PQCs.
Excuse me. Thank you, Aisha. So as Jamie said earlier, I'm Stacy Penny, and I lead the National Network of Perinatal Quality Collaboratives at NICU, and we provide support, technical assistance, and guidance to all PQCs around the country to help them with regards to their efforts to improve maternal and infant health outcomes. You heard from a few PQCs on the line today. Shout out to them. Thanks for being here. But in addition, there are 48 PQCs in the US, and they each have a diverse network that are composed of hospitals, clinicians, researchers, community leaders, patients, and families. And over the last few decades, PQCs across the country have used data-driven, evidence-based quality improvement principles and methods such as patient safety bundles to advance clinical processes and practices, reduce care variation, address gaps, and also optimize resources to make measurable improvements in maternal and infant health. So as we all saw recently with the 2021 maternal mortality data, that this really emphasizes, looking at that data really emphasizes the importance of PQCs as they work to drive systems level change in hospitals and facilities to not only reduce inequities in the country with regards to Black and Brown women, but also really using their large networks of birthing hospitals to allow for data sharing, peer-to-peer learning, and dissemination of best practices. So PQCs really are very unique and uniquely positioned to prevent adverse maternal health outcomes and reduce maternal deaths through the work that they've done around, many of them have done around opioid use disorder. And this really just translates over to the topic that we're here to talk about today, which is regards to maternal mental health. And we have a few PQCs, including Colorado, who's on the line, who are embarking and getting into this work more. And so I'm just really excited to launch into today's conversation and get and hear from everyone. So thank you. I'll turn it back to you, Aisha, or actually to Jamie, I think, who's going to talk about our whole mom standards.
Yeah, thank you. And I'm going to go ahead and share my screen. Majority of the time we'll spend for the remainder of the session will be talking through some questions and having some discussion. But before we dive into that, I want to share one of the 2020 Mom resources that we think is really helpful, and would like to get some information from y'all about, have you seen it? Is anybody using it? And that sort of thing. So I'm going to go ahead and pop this up on my screen, and then Aisha is actually going to throw this into the chat as a link as well, so that you can bring it up on your screen. You can use it after, and we will make sure that these resources are available to you after the session today as well. So let me go ahead and figure out how to use this. Okay, and to show you how to get here very quickly, as I mentioned, Aisha's going to pop that in chat. But if you are familiar with the 2020 Mom website, and hopefully you are, you'll see that there's a resource section, and you will see the whole mom survey located there. So what you're seeing on your screen is just an image of that, so that it looks familiar when you go to find this tool or resource for your use. And it talks a little bit about the background of how you can become a whole mom hospital. This is really meant to be a self-assessment for hospitals and for communities to better understand what's happening in their local hospitals. So what I'm going to do next is show you what that actually looks like. It is segmented into sections by topic, and it's super useful, and it's something that can even guide our conversation today when we think about what are we doing to address maternal mental health in our states and through our PQCs. And the cool thing I think about this tool is you actually complete it and you submit it, and 2020 Mom will acknowledge that receipt and promote you as a whole mom hospital. And so it's also another way to share with the public and share with your community and share with your partners that you are committed and that you are doing this work that is very important in the maternal health space. And so it walks us through sections like training. So talking about the nurses that are working in the units, what kind of training are they receiving? What types of resources do you have on staff? It then takes you through curriculum. So, what are you doing to educate your staff? Grand rounds, other types of content that might be shared, and what that looks like. Also talks through resources, policies, procedures, and practices. So universal screening, I heard somebody mention that, talks about observation, discharge packages, and a number of other really great things that all hospitals, we would hope, would be doing around this topic. And then takes you through programs as the last topic. So this is another thing I think we can talk through today is, new parent support groups, other types of ways that you're ensuring that your patients are aware of certain resources and different resources that might be available through the hospital, through the community, and through your partnerships, whether they be outpatient or inpatient. So I just wanted to share that resource as we start into our questions and our discussion today. It's something you all have access to and can use. Your hospitals can use it. So we'd encourage you to do that. It's something tangible you can take away from today and from the forum as a tool to really help support your work and really move things along. So I'll ask a quick question, and feel free to, go ahead and chat this in. But is anybody aware of the Whole Mom Survey? And if the answer is yes, do you know of any hospitals in your state that are using it? So we'd love to hear a little bit more about that as we dive into our questions for the session. So again, link is here in the presentation, will be available afterward and will be chatted in, and you can always find that amazing resource on the 2020 Mom site. But let's go ahead and open that up. So anybody aware of it, and feel free to come off mute too if you prefer to talk versus chatting it in and messaging. We'd love to hear a little bit more from you. Right, got a few chats coming in. And Stacy and Aisha, feel free to pop up if you're seeing a little more than I am.
Not at the moment. Most are saying maybe not. We're aware of it.
Okay.
Yeah.
All right, so some not aware, great. A couple, I see Katie Brassfield aware of it, not sure if anyone's using it. Katie Breen as well, great, okay. All right, so a little bit of a mix there, a few folks who are and who aren't aware. So you learned one thing today, and hopefully you can go share that. You'll learn a lot more in a couple minutes too, I promise. But that's one tool you can take with you. And 2020 Mom is really excited to help support that work. So feel free to contact us as well if you have other questions about the use of it or need some coaching through it. All right, I'm going to pop up our questions, Stacy and Aisha, for the group.
Yes. So I'll kick off the first question. So I heard a few of my fellow PQC colleagues on the call, and I think it would be great for those who are not in PQCs, as we know this is a great opportunity for peer-to-peer learning, just for either Susan or Katie or Kate or Elena, and I heard someone also from California. Just really, if you'd love to kind of talk about how you might be addressing maternal mental health in the state, excuse me, and with your partners and in your hospitals. And Katie and Elena, I'm going to select you first, not volunteering you, but you guys have really started this and kind of leading the way for so many other PQCs. Would love to just kind of hear about the work that you all are doing and how this is coming along.
Sure. So I will focus on two different types of work. The first one I'll talk about is our clinical quality improvement projects. So one of the ways that we're addressing maternal mental health through clinical QI is, so our state is implementing the AIM substance use disorder bundle. We're implementing it for the state. But what we've done is, because we know that substance use and maternal mental health are super important, we've added in some elements related to maternal mental health into that learning collaborative, even though it technically is substance use disorder collaborative. And people might be asking, like, well, why didn't you just do the maternal mental health bundle? And that's because the MMH one wasn't officially completed until earlier this year, but the SUD bundle has been around for a little while. So we chose the fully formed SUD bundle that had like a data collection plan fully fleshed out by AIM, and then decided to supplement it with maternal mental health pieces. So we added in measures related to maternal mental health, like screening for maternal mental health, protocols for maternal mental health. And then as part of the provider education that we offer as part of the learning collaborative, we're not only talking about SUD, but we're also talking about MMH either separately or as a comorbidity of substance use disorder. So that's that. And then the other side that where we work really heavily on maternal mental health is we're the backbone organization for what's called the Colorado Maternal Mental Health Collaborative. And that group has various work groups focusing on different aspects of maternal mental health. So there's a policy and financing work group. There is one that is focused more on like what patient-facing resources we can provide related to maternal mental health. That backbone organization, actually, yesterday we hosted an in-person convening to watch 2020 Mom Forum all together. And so that collaborative, whereas the first thing I talked about is focused on inpatient L&D units in hospitals, the maternal mental health collaborative is much more cross-cutting and multi-sectoral. So outpatient maternal mental health practitioners, outpatient, family medicine or OB docs. There's definitely some inpatient people, public health agencies, direct service organizations, PSI, peer support organizations. So really more community outpatient and multi-sectoral. And then the first thing I talked about is really just focused in hospitals, even though we also encourage them to span the continuum of care, but that's a little bit farther down the road, I think, till we get to a more sustainable place with actually making an AIM bundle multi-sectoral.
Sorry, I'm trying to find the mute button. Thank you so much for sharing that, and just really appreciate all the work that you all are doing. And it's, on top of the other initiatives that you're doing as well. But we know how much all of these are aligned with each other to ensure that moms are having the most optimal health outcomes that they can have. Anyone else? Susan, or I lost the other person. Susan, you came up first in my Hollywood Squares here. I calling on you. All right, then. I'll take number 1 for 500, please. So what I would say, like Katie mentioned, that their perinatal mental health or maternal mental health is embedded in their SUD bundle. I would say the same is occurring in Ohio. We have been working, like I said, in that opioid use disorder space for a number of years. We had a project, a Moms Plus project, that was focused on collaborative care amongst the providers who are caring for a mom with an OUD while she's pregnant. And it was really one of the first opportunities I had within the PQC to work with the behavioral health care specialists. And I think that what I learned in that project, what we learned, was that it's so important, especially for this population, to include that type of care. And we also found some areas of the state, particularly in the Appalachian areas and real rural areas, they were struggling to try and find behavioral health providers. I think the state has done a lot with the ability to provide that via telehealth. I do think that the pandemic also impacted that. Some of the sites we work with had great opportunities for group counseling or group centering meetings and had behavioral health and mental health addressed at those meetings. And obviously that came to a screeching halt in the pandemic. Some of those sites have been able, some of those hospitals have been able to reorganize and reopen those opportunities for their patients, but not everyone has, sadly. I do think that it's, there's so much data out there from the sequelae and impact of the pandemic that we really don't have good data on. And I think that an opportunity just like that they had this wonderful centering program in place and great opportunity for peer support, peer sharing for their behavioral health aspect, and just they haven't, teams haven't been able to get back to that. I do think what also is important to talk about is health equity incorporated into that. And I think of that also as a bit of a marginalized population with the stigma towards moms with OUD, especially those that are pregnant. And we work with our PQC a lot on stigma. We have our team epidemiologist, Dr. Nicole Knighty, has a group of moms that have lived experience that she works with. And some of the information and some of the sharings from the mom are difficult to hear, but I think that it just really hits home the need for the support and the need for that. I'd also like to address, Stacey, the last question you have up here on the slide. What resources do you need to advance and scale, and how can hospitals help? I think the secret sauce of the PQCs is the share seamlessly, steal shamelessly. And I have learned so much from working with other PQCs, adapting or adopting other things that they have and sharing what we've found to work and what hasn't. I think that with the space of the SUD, thinking about that SBIRT with the referral to treatment, and that's not just referral to medication assisted treatment, but behavioral health treatment too, because that mental health piece cannot be ignored when you're dealing with a diagnosis such as that. Those are my thoughts from Ohio. Oh, sorry, go ahead, Jimmy. Thank you so much, Susan. Thank you.
Yeah, I was just gonna agree, Susan. Totally agree. And I think it's okay that you're jumping around on the questions here, because I do think we heard at least some of the comments already about some challenges and lack of resources, lack of providers, and so it helps continue the conversation about what are folks currently doing and kind of lens right into what are successes and challenges and learnings that folks can share. So yeah, and I know we do have an order, and that was kind of my topic. So I'll open that up maybe for anybody else who wants to weigh in on successes, challenges, or learnings in the work that you're doing. And I do see some chat coming in. I apologize, I'm a little slow with sharing my screen and catching the chat, but it looks like there's some good conversation and some questions taking place. And feel free to come off mute if you want to dive in a little deeper into some of that. we don't have to exactly go with every single question in this order. So good conversation. And if anybody wants to come off mute and chime in on some of those successes, challenges, or learnings in your state, that'd be great.
And Jamie, if I may, I just had an example. This is not successes or challenges, but it is the work of Kansas PQC. They recently created an initiative called the Fourth Trimester Initiative. So with that, what they're doing is they've had birth facilities enroll into the initiative and enroll into the an AIM, sorry, let me just read the AIM bundle that they have. They enrolled into the AIMS postpartum transition safety bundle. And the work started in 2021. So at this stage, they're collecting data and they're really focusing on the postpartum phase. So making sure that the screenings for depression or any type of anxiety disorders are being screened. There's follow-up as well. They're also providing all these resources at no cost and really integrating different types of, really using all the types of healthcare professionals to be a part of this initiative so that they're meeting the needs of the patient at different levels. So I just wanted to share that example, and I can drop the link to their information in the chat if anybody's interested in learning more about their work. I did invite them to the session and they were unable to make it, so I just wanted to plug their program in. So I'll drop the link in.
Great, thanks, Aisha. And I too was looking for my mute button. So, and I know we are going a little bit out of order, Aisha, and I know this was another one that you particularly wanted to bring up is maybe folks could share how health equity is being incorporated into their work. That certainly is at the forefront of a lot of PQC work. I know from having personally been there, but would anybody be willing to share some of what you're doing to really incorporate health equity into this work in the maternal mental health space?
And I know some of you are from PQCs and some of you are not, but I think it'd be just helpful just to know just how are you talking about it with your partners, with your staff, or with your patients, communities. Just having that conversation I think is very important. So we'd just love to hear.
Sounds like Katie might have some ideas that she's chatting in, and maybe because I know her, could call on her to talk more about the program to incorporate patient and family voices into their work. I think folks would love to hear more about that, Katie Breen.
Sure. Yeah, so we have a program called FIRST, which stands for Family Integration to Restore Trust. And essentially how it works is that family or patient advocates apply to the program. When they enter the program, they go through a training to become, it's a Mama's Voices training, so it's national training, to become like patient advocates. And then once they've gone through that training, we then figure out like where their interests lie, and then essentially place them into leadership positions within our PQC. So for example, if someone's really interested in maternal mental health, we might, they might decide to be the patient advocate on a steering committee related to our maternal mental health work. If they had a traumatic C-section, they might choose to get involved in our C-section work. So that is sort of where health equity comes into our programs a lot. And I mean equity at a very broad level: racial equity, socioeconomic equity, educational level equity, yeah, so making sure that the actual patient voices are heard and are part of the decision-making process of all of our programs and services offered by the PQC. And we compensate them.
Oh, yes, Katie,
That's important.
That's really important. Yeah, very important. We've learned that, right? Is folks, and I think equitable compensation is, for anyone who has a need for something that would help support them in their participation, right? So that looks different for everybody. Could be transportation, could be childcare, could be, financial compensation for time away from a job, right? Just and ensuring that it's available to anyone to participate, to ensure that their voice is heard and they are a member, equal participant in the work. I think that's, yes, very important.
I can add one more thing that sort of is probably a more traditional way to talk about equity or address equity, which is that our state, so we have collaborated with the state on this, but our Department of Public Health has a survey called Healthy Moms. It's similar to PRAMS, which you're all probably familiar with, but it's only in the state of Colorado, and it focuses a lot on maternal mental health. And one of the things that we have done in conjunction with the state is essentially gotten dedicated funding for that program to be able to oversample communities of color, so that we can actually get the perspective of communities of color in to come forward in our data, because that was a place that we really struggled with getting good data related to maternal mental health, but related to maternal outcomes in general. And so one of the things we've done is figured out how we can design programs that like really intentionally are hearing from voices of the entire community. And one of the ways we did that is through this data program where we got funding to oversample certain populations. And I'll shut up now.
No, that's great. And I think a lot of people are chiming in chat too, about Katie Brassfield. They're working with a nonprofit as well, Alive and Well, which provides equity-centered trauma-informed care education to the PQC member hospitals. So that sounds amazing. I know collaboration with other entities who do things well already, have some established, curriculum and structure is always valuable. Sounds like March of Dimes, stigma bias equity training has popped up in the chat. Others are saying the old thing about if you can't see it, if you're not measuring it, you can't change it, right? So collecting data, really looking at race, ethnicity, zip codes, where people live, right? Income, poverty levels, that sort of thing, right? So I think that's important. And others are mentioning, and being mindful about who needs to be at the table. And constantly, I love that about, quality improvement is like, keep getting better, right? Like who's not here consistently evaluating and reevaluating. It's an ongoing process and it's ever changing. So hearing some great things in chat. All right.
I know we have 2 minutes left, Jamie. So just wanted to ask all of you, what kind of resources do you need to help your work? Is there something that the hospitals can help you with? Is there something that Stacy, Jamie, and I, is there something that you need to really kind of hone down on what's going to support you in the long run?
I would say in Ohio, I love learning about what other PQCs are doing. So any type of educational materials or perhaps screening tools, things like that, specific to mental health, I think that would be very helpful. And perhaps even Stacy, maybe on NNPQC website or something like that, like a tab where we would be able to access tools like that, I think would be very, very helpful. Also, education tools for providers. I think that the March of Dimes equity is a great example of that. And I just think that mental health has a lot of stigma around it. Also like OUD or SUD diagnosis. And how do we mitigate that? How do we work with people that, this is a disease, there are treatments for it, and to get some of that stigma and shame away, I would find very helpful for us.
Love that. And I see folks are chatting in some links. And that's one thing we really want to ask of you all today. Keep the conversation going. If you don't mind and are open to it, you can pop your name, pop it in chat. Maybe take away the initiative to say, I'm going to introduce myself to one person on this call today that I didn't know who might be doing something that I can learn about, or I might be able to share with them. If you have a resource that you love that's really valuable, if you want to stick that in the chat, a link to it, that'd be awesome. But we really encourage you, this is great conversation and good discussion, but we really want to keep it going, and we want to move forward to next steps, to the doing phase, right? And so Stacey, I know you have some comments about that, but I'm loving it. I'm already seeing it coming in. So let's share our emails, let's share our resources, let's continue to do this work together. This is awesome. I see I'm popping in.
Well, thank you, ladies, for such a great discussion. And I know there's always so much more to as the fly on the wall, but we really appreciate everyone being here. You're putting your stuff into the chat, so we're going to hang on so you ladies can copy that down as needed. But we are going to wrap for the day, so we'll see you all tomorrow at 9:30 a.m. Pacific for day 3.
Thank you all so
Thank
much
you,
for
everyone.
joining us today.
Thanks, everyone. Have a great day.
Bye.
Thanks all.
Yeah.
Jamie.
Are you guys together?
Yeah, in Denver.
Oh, that's awesome.
We had an in-person team thing today.
Yay.
Yeah.
Look at your little faces.
All right. Do you all have everything you need from chat?
Yes, I saved the chat, Stacey. I can.
Oh, great.
Send it
Perfect.
to you.
All right. So you are all set. All right, ladies. Thank you so much. Have a great rest of your day.
Awesome. Thanks, Stacey. See you guys. I don't know if they're using this Zoom. That would be weird.
I don't know either. Bye, Jamie.
Bye.